medical negligence affecting the elderly here in the Netherlands.
Absolutely. It's a significant issue.
We've got a study by Layli Maradi, which was part of a university program, and a collection of other documents that should give us a pretty good overview. So what specifically made this topic jump out at you?
Well, what's particularly striking when we look at the sources is the increasing vulnerability of the elderly population in the Netherlands. We're seeing more people living longer, often with complex chronic conditions, and the healthcare system itself is facing some, well, significant challenges. This convergence really puts a spotlight on potential risks in their medical care.
Absolutely. And as we age, our bodies don't always bounce back as easily, right?
Exactly.
That can make us more susceptible to oversights or errors in treatment. Plus, you've highlighted this ongoing shift towards more home-based care with the Long-Term Care Act, the WILS reforms.
Yes, that's a crucial element here.
It's a big shift in how care is delivered. And it inevitably creates new intersections with the potential for medical negligence. So for you, what's the key question we're trying to answer with this deep dive?
For me, the core mission here is to really understand the current situation. Medical negligence impacting the elderly in the Netherlands, especially with these evolving care models.
Right.
That means getting a firm handle on the facts, understanding the legal elements involved, and maybe most importantly, exploring potential ways to improve things as more care shifts into the home.
Okay, so let's dig into just how vulnerable older people living at home can be. One of the sources you shared is a study titled Safety Risks Among Frail Older People Living at Home in the Netherlands. What were your initial takeaways from that?
Well, what immediately stands out is that over 80% of elderly individuals in this situation face multiple risks at the same time.
80%. That's a really high number.
It is. And that's across their physical health, their lifestyle, and their social surroundings. It's a significant overlap of vulnerabilities.
What kinds of risks are we talking about here specifically?
The study points to several key contributing factors. High prevalence of existing cardiovascular conditions, which, isn't entirely surprising given the age group.
Sure.
But also significant are cognitive impairments, things like dementia, or even just general age-related memory issues. Then you have limitations in their ability to do everyday tasks, which naturally increases reliance on others. And the issue of polypharmacy.
Taking multiple medications.
Exactly. Taking lots of different medicines, which can unfortunately increase the risk of errors or bad interaction.
Right. And it's not just physical health, is it? You mentioned social environment, too.
Precisely. A lack of strong social support can leave people feeling isolated, less able to advocate for themselves, or even have someone notice if their care isn't quite right.
That isolation can really compound things.
It really can. These vulnerabilities rarely exist in isolation. They interact, often making each other worse.
Can you give an example?
Sure. Someone with, say, both a heart condition and some cognitive impairment, living alone. Well, they're facing a much more complex situation than someone with only one of those issues who has strong family support.
Right.
This intricate interplay is what significantly elevates their risk of severe disabilities and, unfortunately, the potential for medical negligence.
That paints a clear picture of the challenges. Building on this, another source you provided is the research paper, Relative Contribution of Various Chronic Diseases and Multimorbidity to Potential Disability Among Dutch Elderly. What did this tell us about the specific diseases we should be aware of?
This paper offers really insightful data. It highlights several chronic diseases that are not only very common among the elderly here, but are also frequently seen in cases linked to disability and, sadly, medical negligence claims.
Okay, let's start with coronary heart disease, or CHD. That was mentioned as a leading cause of disability for older men.
Yes, CHD is indeed flagged as the leading cause of disability for elderly men in the Netherlands. The study suggests a man aged 65 might expect to live around another 7.6 years with the condition.
And negligence claims related to CHD often involve what?
We often see issues around delayed diagnosis, especially of acute events like heart attacks or instances where the management, once diagnosed, wasn't quite right.
Okay. And for women, it seems osteoarthritis plays a major role.
That's correct. Osteoarthritis is the most common cause of disability among elderly women. A woman aged 65 might live nearly 12 years with it.
12 years? Wow.
Yeah. And while it's not typically fatal, it can be incredibly debilitating, really impacting quality of life. Negligence claims here often revolve around inadequate pain management, maybe inappropriate treatments being offered, or complications from surgeries like joint replacements.
Diabetes is another big one affecting a lot of older people.
Absolutely. Highly prevalent, Major contributor to disability for both men and women. Men at 65 can expect about 7 years with it, women around 6.5 years.
And the claims?
Often involve failures in managing blood sugar properly, which can sadly lead to severe complications, nerve damage, kidney issues, even amputations.
We also see congestive heart failure, CHF, listed.
Yes. While the average number of years lived with CHF might seem lower, maybe 2.3 years, for men at 65, it still contributes significantly to disability. Claims often concern medication management, not enough monitoring, or problems with emergency care when things flare up.
And what about respiratory illnesses like COPD?
Chronic obstructive pulmonary disease, another major cause of disability. Claims here often relate to managing acute respiratory failure, delays in getting the diagnosis right, or sometimes improper ventilator use in severe cases.
Stroke, too. That can have a huge impact on daily life.
Definitely. Maybe not as many years live with the disease compared to some others, but a stroke is a significant cause of long-term disability. Claims often involve delays in getting that crucial, time-sensitive treatment or issues during rehab afterwards.
And finally, dementia. That presents immense challenges.
It really does. Dementia contributes significantly to the time older people spend living with the disease, especially over 80. Claims can involve misdiagnosis, poor management of symptoms, or even failures in nursing home care.
It's quite sobering seeing how these common diseases aren't just burdens themselves, but also areas where negligence can happen, making things even worse. You mentioned how they cause disability through reduced mobility dependence. Could you give some specific examples?
Certainly. Take osteoarthritis again, the chronic joint pain and stiffness. That can severely restrict movement, making simple daily things like dressing or cooking really hard. It leads straight to less mobility and needing more help. With diabetes, as we said, complications can be devastating. Vision loss impacts independence hugely. Kidney failure means complex treatments. Amputation drastically cuts physical ability.
And it sounds like having more than one of these conditions really ramps up the difficulty.
Absolutely. The research really underscores the role of multimorbidity. It's a critical point.
Like which combinations are particularly bad?
Well, the combination of diabetes and osteoarthritis. That leads to the most years lived with disability for both men and women in this age group.
Really?
More than others.
Yes. Managing multiple chronic conditions is just inherently complex. It needs careful coordination between different doctors, understanding how treatments interact. This complexity, unfortunately, raises the odds of errors happening. Medication mistakes, maybe choosing the wrong treatment path because of the interacting conditions.
Any other particularly tough combinations?
The co-occurrence of CHF and CHD is another one that significantly increases the overall burden of disability.
So we've talked about the prevalence and how these diseases contribute. The study also quantifies this impact as a percentage of remaining life expectancy. That's quite a stark way to look at it. Can you walk us through some of those numbers?
Yes, it really puts the long-term impact into perspective. Let's take osteoarthritis for women age 65. They might spend around 55.8% over half of their remaining life living with disability from that condition.
Over half.
And by age 85, that jumps to 73.1%. Wow. And for men with osteoarthritis.
Still substantial, though generally lower. 40.7% at age 65, rising to 63.0% at age 85.
Those are really significant portions of life. What about CHD for men? That was the leading cause of disability for them.
Right. For men age 65 with CHD, they could spend roughly 43.4% of their remaining life with disability from it, climbing to 69.2% by age 85.
And for women with CHD?
Lower, but still noteworthy.
24.0%
at 65 and 39.8% at 85.
In diabetes.
Also a considerable impact. Men at 65, around 40.2% of remaining life with disability due to diabetes, increasing to 60.4% at 85. For women, it's 31.0% at 65 and 45.2% at 85.
Women 9.9% at 65, 21.4% at 85. For CHF men at 65, it's about 13.3%, rising to 31.5% at 85. Women, 20.1% at 65, 25.4% at 85.
And stroke.
It's still a notable impact. Men at 65, 13.2%, increasing to 27.1% at 85. Women, 9.8% at 65 and 17.3% at 85. Finally, dementia. You said the share might be lower compared to some physical conditions, but it still hits quality of life hard, especially later on.
Exactly. For those who reach 85, men might spend around 10.2% of their remaining life living with dementia. Women, about 11.1%.
And you flagged the really huge increase when conditions combine, like diabetes plus osteoarthritis or CHF plus CHD. Those combined numbers were shocking.
They are indeed. For instance, diabetes and osteoarthritis combined can lead to over 90% of remaining life spent with disability for both men and women at 85.
90%.
And CHF combined with CHD, over 94% for men in that same age group. These figures really hammer home the immense challenges for elderly people with multiple chronic conditions and why high-quality coordinated care is absolutely critical to minimize disability and, well, the risk of negligence.
Okay, so with that understanding of the vulnerabilities and the specific diseases, let's turn to the legal side here in the Netherlands. What are the key laws that come into play when we talk about medical negligence involving the elderly?
In the Netherlands, the main legal framework is rooted in the Dutch Civil Code, specifically Book 7, which deals with medical treatment agreements.
Okay, Book 7.
Yes. It lays out the basic standards of care patients are entitled to. Then there's Book 6 of the Civil Code, which covers the broader law of obligations that's crucial for liability and claiming damages when harm occurs due to negligence.
So the Civil Code gives the foundation. What other laws are important here?
We also have the Medical Treatment Contracts Act, known widely as the WGBO.
Right, the WGBO.
This act really zooms in on patient rights and provider obligations within that treatment relationship. Big emphasis on informed consent, patient autonomy, their right to decide, and the overall duty of care professionals owe patients. For elderly patients, the WGBO's provisions are particularly relevant.
How so? In what specific ways is it extra important for older patients?
We'll think about the patient's right to information. That's vital for older patients who might need more time, clear explanations, or extra support to really grasp complex medical details.
Makes sense.
Then there's informed consent itself, making sure patients truly understand and agree to treatment. That takes on even greater weight if someone has cognitive issues. The WGBO also requires proper documentation and record keeping essential if there's a negligence claim later.
Okay.
Plus, it guarantees privacy, confidentiality, access to medical records, and importantly, sets up ways for patients to seek redress if they feel their rights weren't respected during treatment.
So the WGBO focuses strongly on protecting the individual patient in that direct interaction. And you mentioned another key law.
Yes, that's the Quality Complaints and Disputes in Healthcare Act, the Wkkgz.
Wkkgz, okay.
This one takes a broader view, focusing on the overall quality of care across the whole system. It mandates that all providers must have robust, accessible complaint procedures, and it requires them to report incidents that could potentially harm patients.
So the Wkkgz is more about the system quality accountability within organizations.
Precisely. It puts a legal duty on providers to consistently deliver safe, effective care. Article 3 requires incident reporting. Articles 12 and 13 detail the requirements for internal complaint procedures and the role of a complaint officer.
And if internal complaints don't work?
Then Article 18 outlines the process for using independent dispute committees. We'll probably talk more about those later. The Act also stresses transparency, Article 8, and ongoing quality assurance to keep improving safety.
It sounds like these two laws, WGBO and Wkkgz, really work together to protect patients.
They do complement each other. WGBO is about the individual patient-provider relationship and rights during treatment. Wkkgz sets the broader framework for quality and accountability across the system, including how complaints are handled when things go wrong.
To really see how these laws work in practice, looking at specific cases is useful. You flagged a few. Let's start with the delayed cancer diagnosis case from 2022. What were the key legal points there?
This case really shows the WGBO and Wkkgz in action. A patient complained after a significant delay in getting a cancer diagnosis, which unfortunately worsened their condition.
Right.
The court found the hospital failed in its duty of care under the WGBO by not acting promptly on earlier test results that strongly suggested cancer.
So failing to provide timely care falls under the WGBO's duty of care.
Exactly. But the Wkkgz also came into play. The court found the hospital hadn't handled the patient's complaints about the delay properly either. They didn't communicate clearly or promptly in response to the concerns raised.
Ah, so a breach of the Wkkgz complaint handling rules too.
Precisely. The court ruled for the patient, emphasizing this dual responsibility: deliver proper, timely care and handle complaints effectively and transparently.
That really shows how they're intertwined. What about the elderly care facility negligence case from 2023? That sounds very relevant to our focus today.
Yes, this involved an elderly resident in a care facility who tragically developed severe bed sores due to what was deemed inadequate care and neglect. The family filed a complaint under the Wkkgz about the care standards and the facility's poor response to earlier concerns. The court found the facility violated both laws.
How so?
The WGBO for failing to provide the necessary care to prevent the bed sores, a clear breach of duty of care to a vulnerable resident. And the Wkkgz for not adequately addressing the family's complaints and failing to implement measures to stop it happening again.
Bed sores are such a serious sign in elderly care, often pointing to neglect of basic needs. This case really highlights the vulnerability.
It does. And the court's decision mandating compensation and significant improvements in complaint handling and care protocols sends a very clear message about the legal protections for elderly people in care and the responsibilities facilities have.
The third case was the surgical error case, also from 2023. What are the lessons there?
This one centered on informed consent, a cornerstone of the WGBO as we discussed. A patient had lasting complications from a surgical error. The patient argued the surgeon failed to adequately inform them of all the material risks before getting consent. Plus, their later complaints about the error weren't handled properly by the hospital, bringing in the Wkkgz.
So, another dual failure.
Yes. The court ruled both the surgeon and hospital failed, awarded damages, and ordered the hospital to review and revise its procedures for getting informed consent and handling complaints.
So across these three different cases, we see this consistent pattern. Provide proper care, ensure patients are fully informed about risks, and take complaints seriously. When any of that falls short, there can be real legal consequences.
Exactly. These cases are practical examples of how WGBO and Wkkgz work together to protect patients, and they underscore how vital these protections are for vulnerable groups like the elderly, where failures can have severe, lasting impacts.
You touched earlier on the critical importance of ensuring understanding, especially for informed consent. This can be a real challenge with elderly people facing cognitive issues, low health literacy, or language barriers. If a patient's understanding is lacking, who bears the legal responsibility?
The primary legal responsibility generally rests with the healthcare provider. Under the WGBO, they have a fundamental, legally binding duty to take all reasonable steps to ensure the patient fully comprehends the information needed to make an informed decision.
What does that involve?
Clearly explaining the diagnosis, the proposed treatment, the foreseeable risks and benefits, any alternatives, and doing it all in a way the specific patient can reasonably be expected to understand.
So using simple language, maybe visual aids, checking comprehension.
Exactly. If the provider fails in this duty, especially with an elderly patient who might have cognitive limits or language barriers, they risk breaching their duty of care. If that failure leads directly to harm, the provider could be held legally liable for negligence.
So it's not enough just to give the info. They have to make sure it's understood.
Precisely. And this is where the potential secondary liability of healthcare institutions comes in.
How so?
Institutions can be held responsible if systemic failures contribute to a lack of understanding. For example, if a hospital doesn't provide qualified interpreters when needed, or if they don't train staff adequately in communication strategies for patients with cognitive challenges.
Okay, so lack of resources or poor policies can make the institution liable.
Potentially, yes.
Yeah.
They could be vicariously liable for employee negligence, or directly liable if they lack clear policies for informed consent, or fail to ensure proper documentation of the consent process.
And what are the potential legal outcomes if consent is deemed invalid due to lack of understanding?
If a patient suffers harm from treatment they didn't validly consent to because they didn't understand, they can pursue an informed consent claim. The courts will examine if the provider took all reasonable steps to ensure comprehension.
And if they didn't?
The patient may be awarded financial compensation for medical expenses, pain and suffering, possibly lost wages. In really bad cases, maybe even punitive damages, though that's less common here.
Is there any specific case law on this?
Well, the Wkkgz case is a landmark, though it didn't directly involve an elderly patient. It strongly emphasizes the provider's duty to actively ensure patients truly comprehend the information. Its principles are definitely applied in cases involving diminished capacity, like sometimes seen with elderly patients.
It's very clear then ensuring genuine understanding, especially with vulnerable elderly patients, is a critical legal responsibility, not just an ethical one, for both individuals and institutions. Now let's shift focus slightly and look at the data on medical negligence claims in the Netherlands. What trends have we seen over the last, say, decade and a half?
We have some informative data, mainly from Centrum de Middenrisk, major insurers, covering 2007 to 2021. Over that 15-year period, there were a total of 20,726 formal claims filed.
Wow, over 20,000.
Yes, averaging around 1,382 claims per year. Interestingly, the data shows a peak around 2013, then a general decline in the following years, with 2021 being the lowest in that period.
That's a substantial number overall. Are there specific medical specialties that see more claims?
Yes, the data consistently shows surgical specialties accounting for a high number. General surgery tops the list, 4,322 claims in that period.
Okay.
Orthopedic surgery is second with 2,353 claims, and gynecology obstetrics third with 1,951. These top three make up a big chunk of all claims.
What about non-surgical specialties? Do they see many claims?
They do. Internal medicine had 1,462 claims, likely reflecting the complexity of diagnosing and managing chronic conditions. Emergency medicine had 1,105, maybe due to the high-pressure, time-sensitive nature of urgent care.
Any others?
Several others had significant numbers, too, between roughly 600 and 850 claims each. Otolaryngology, ENT, radiology, ophthalmology, plastic surgery, and neurology.
And what are the common types of errors alleged in these claims within those top specialties?
In general surgery, it's often surgical errors themselves, wrong site surgery, things left inside, or postoperative complications blamed on negligence, delays in diagnosis or treatment.
Okay.
Orthopedics.
Often mismanagement of fractures, complications after joint replacements, surgical errors during those procedures, other post-op issues.
And gynobs.
Frequently relates to birth injuries to mother or baby, alleged errors in managing pregnancy or delivery, surgical complications from C-sections or hysterectomies.
What about internal medicine and emergency?
Internal medicine often sees claims about diagnostic errors, medication mistakes, or inadequate management of chronic diseases. Emergency medicine claims frequently involve alleged failures to diagnose life-threatening conditions quickly enough or delays in starting critical treatment.
And what happens with these claims? Are they usually accepted, settled, or rejected?
It varies by specialty. In general surgery, for example, about 25% were accepted by the insurer, around 20% settled out of court, and roughly 50% were ultimately rejected.
So about half are rejected in general surgery. Yes, and orthopedics shows a fairly similar pattern. Gynecology obstetrics, though, tends to have slightly higher rates of acceptance and settlement.
Why might that be?
Possibly reflects the often severe and well-documented nature of the injuries, especially birth injuries. Radiology also stands out for claims about diagnostic errors, missing things on scans. While many of those are rejected, the ones accepted can lead to big payouts due to the harm from delayed diagnosis.
So overall, quite a few claims get rejected.
Yes, across most specialties, a significant proportion are rejected, often due to lack of sufficient evidence for negligence or not meeting the legal threshold for malpractice.
It seems surgical and diagnostic fields are particularly prone to claims, and outcomes vary a lot. Now let's switch to how the recent Long-Term Care Act reforms, the WGBO, might impact this landscape, especially with more elderly care moving into homes.
This is a really critical area. The WGBO, fully implemented in July 2023, has definitely shifted responsibility for care. The emphasis moved from formal professionals towards relying more on informal networks, family, friends, volunteers.
Why the shift?
Largely driven by rising healthcare costs and growing shortages of qualified healthcare staff, especially in elderly care.
And what are the potential challenges arising from this move to informal caregiving?
While it aims to ease pressure on the formal system, it puts a huge burden on families and individuals now providing care. Many informal caregivers might lack the time, specialized training, or financial resources for complex elderly care needs.
That sounds tough.
It is. Caregiving demands can be exhausting physically, emotionally, mentally, leading to caregiver burnout. And there are financial hits, too. Maybe reducing work hours or leaving jobs, losing income.
And how might this reliance on informal caregivers intersect with medical negligence, which usually focuses on trained professionals?
This is where it gets complex and raises new legal questions. Traditionally, negligence means a licensed professional fails to meet the accepted standard of practice, causing harm. But when care shifts to people without formal training or licenses, what is the standard of care? It becomes much harder to define and apply. Informal caregivers, despite best intentions, might unintentionally cause harm due to lack of knowledge, poor technique, or not spotting subtle signs of decline.
So you can't really hold them to the same standard as a doctor or nurse.
Exactly. It's problematic. This evolving landscape might well need legal reforms for clearer guidelines on expectations and responsibilities for informal caregivers.
What might that look like?
Maybe mandatory basic training. Minimum care standards they'd be expected to meet to avoid liability if acting in good faith. This could offer some protection to caregivers and ensure a baseline of safe care for the elderly. There might also need to be a legal distinction between negligence by professionals versus issues involving informal caregivers, recognizing the huge difference in expertise and responsibility.
So the existing legal framework might need to adapt. Anything else to consider with these WGBO reforms?
Yes. The government is also looking at tech solutions, digital health tools, AI, to help with workforce shortages and support informal caregivers.
AI in caregiving.
Potentially assisting with things like patient records, medication reminders, maybe offering guidance in common situations. But it's crucial to remember this tech is still early stage. It'll likely take time before it has a widespread impact.
So in the meantime,
it's essential that informal caregivers get adequate professional support and resources. And there need to be clear pathways for prompt medical help when an older person's health worsens or complex issues arise beyond the caregiver's ability.
this integrated approach is vital to reduce risks in this evolving model.
It's a really multifaceted issue then, balancing cost-effective home care with safety, quality treatment, and figuring out accountability in this new landscape. Now let's turn to another important mechanism, the role of dispute committees in the Netherlands. What are they and how do they work? The dispute committees are an important alternative pathway for patients to resolve complaints and seek redress for healthcare issues, including negligence allegations, without necessarily going through the often long and costly civil court system.
So faster and cheaper.
Generally, yes. The goal is a process that's faster, less expensive, and less adversarial for patients who feel harmed by their care.
How do they operate?
Through a hybrid procedure. A patient can file both a formal complaint about the provider's actions and a claim for financial compensation, up to €25,000 all in one go.
Ah, streamlined.
Exactly. And importantly, since January 2017, because of the Wkkgz, all healthcare providers must be affiliated with a recognized dispute committee. So every patient has access to this independent mechanism.
Mandatory for all providers. That sounds like wide coverage. How many committees are there and what did they cover?
The number has grown quite a bit. By 2022, there were 41 recognized committees. They cover a huge range of sectors: hospitals, mental health, GPs, midwifery, dentistry, psychiatry, pretty much everything.
And who oversees these committees? How is fairness ensured?
There's a clear structure. At the top is the Foundation for Consumer Complaints Boards, SGC. It's an umbrella body ensuring committees follow legal rules and standards. Its board includes consumer reps, provider reps, and independent members appointed by the Minister of Justice.
And government oversight.
Yes, the Ministry of Health, Welfare, and Sport plays a key role, ensuring compliance with the Wkkgz and consistency with quality goals. Committees need government approval to operate, ensuring transparent, independent, fair procedures, and crucially, their decisions are legally binding.
Legally binding. Okay. So for a patient with a grievance, how do they actually use this system? What's the first step?
First step is filing a formal written complaint with the specific committee affiliated with the provider or institution involved, usually done online, but mail is often an option too.
What needs to be in the complaint?
A clear account of what happened, how the patient feels wronged or harmed, and what outcome they're hoping for. Plus, any supporting documents, medical records, letters, etc. There's usually a small admin fee, maybe $50 to $150, much less than court costs.
And they can claim damages up to $25,000 at the same time.
Yes, that's an option, though not required. Importantly, patients don't need a lawyer, which makes it more accessible.
What happens after the complaint is filed? What's the hearing like?
The committee reviews the case, checks jurisdiction and information, then usually schedules a hearing. Both patient and provider get a chance to present their side and answer questions.
Who sits on the committee?
Typically a panel of 3 to 5 independent members. Usually includes a legal professional as chair, someone bringing a patient perspective, and one or more healthcare professionals with relevant expertise.
And during the hearing?
Both sides present their story, provide evidence. Patients can attend in person, but aren't usually obligated to the case, can be reviewed based on written submissions, or they can send a representative.
And the outcome? What kind of decision does the committee reach?
After the hearing, they deliberate and issue a formal, legally binding written decision, usually within 6 months of the complaint being filed.
What does the decision say?
It states if the complaint is well-founded, partially founded, or unfounded. If damages were claimed, it decides whether to award compensation and how much, up to that $25,000 cap. They might also include recommendations for the provider to improve practices or communication to prevent future issues.
And these verdicts are published?
Yes, typically in an anonymized format to promote transparency and learning across the healthcare system.
And once the decision is issued, is that the end of it for the patient?
Generally, yes. The decision is binding. Appeal options are limited maybe for significant procedural errors or substantial new evidence, but much more restricted than appealing a court decision. Some committees also have a compliance guarantee. If the provider doesn't comply, their industry body might step in to enforce the ruling.
It sounds like a potentially very useful system, but what's the actual experience like for patients going through it?
Research shows a mix of experiences. Many appreciate it being faster and cheaper than court. But some report feeling a power imbalance during hearings, feeling less prepared than providers who might have legal backup. Some also describe feeling their personal account isn't given as much weight as the medical professionals views something called epistemic injustice.
That sounds frustrating.
It can be. The emotional toll of recounting distressing events is also significant, and feelings about compensation vary. Many prioritize acknowledgement of harm over the money itself. Some also wish for more follow-up afterwards, a chance to discuss findings, understand what steps will be taken. That can help with closure.
That's a really crucial point. The human element, feeling heard and validated, is key even within this formal process. And you mentioned what providers can do to rebuild trust afterwards. That seems vital.
Absolutely. Even if the ruling isn't entirely in the patient's favor, taking proactive steps helps. Genuinely acknowledging the ruling, admitting any identified errors, implementing recommendations, engaging in open, empathetic communication that can go a long way to rebuilding trust.
So follow-up and demonstrating learning are important too.
Vital. Regular follow-up, showing a sincere commitment to learning from mistakes that fosters a more responsive, accountable, and ultimately trustworthy healthcare system.
This has been a truly insightful and comprehensive deep dive into a really complex, crucial area. Just to recap some key takeaways. We've looked at the specific vulnerabilities of the elderly in the Netherlands, the common medical conditions in negligence claims and their impact on disability, the key legal frameworks like WGBO and Wkkgz.
The new complexities from the shift to home-based care under the Wills reforms.
Right, and the important role of dispute committees as an alternative resolution path. It's so clear this is multifaceted and needing medical knowledge, legal understanding, and awareness of societal shifts in caregiving.
Indeed. It really highlights the ongoing critical need to ensure that as the Netherlands adapts its healthcare system, especially for long-term elderly care, the fundamental rights, safety, and well-being of its seniors remain absolutely paramount.
And on that crucial note, here's a final thought for you, our listeners, to consider. Given this increasing reliance on informal care networks in the Netherlands, how can the nation best strike a sustainable balance? A balance between the pressing need for affordable, accessible care and the fundamental right of its elderly citizens to receive high-quality, safe medical treatment. And what specific, perhaps innovative roles can technology and clearer, more adaptive legal guidelines play in effectively bridging this critical, evolving gap in elderly care? Thank you for joining us for this deep dive.